Okay, you're in the ICU. The pressure's on. You've got a patient who is severely acidotic. Their bicarb is in the basement, and you have to make a call. Do you give bicarbonate? Today, we're going to build a rock-solid framework so you can answer that question with confidence every single time. So picture this. The morning labs pop up on your screen. The pH is low, bicarb is in the single digits, and that gut instinct, that temptation kicks in. You just want to push an amp of bicarb to fix the number, right? It feels proactive. It feels like you're doing something. But that temptation can actually lead you and your patient down a really dangerous path. Let's find out why.
The first thing we have to get straight is what bicarbonate actually is. It's just a buffer, a temporary patch job. Think of it like this. It's a sandbag against a flood. Yeah, it might hold the water back for a little bit, but it does absolutely nothing to stop the rain. It's not going to fix the sepsis, it's not going to provide insulin for DKA, and it sure isn't a replacement for dialysis. All it does is buy you a little time. And as we're about to see, sometimes it makes things a whole lot worse.
So, how can trying to help actually backfire? This is where it gets really interesting. Let's dive into the counterintuitive danger of giving bicarb too soon. This is the big twist. Giving bicarbonate can actually worsen what we call intracellular acidosis. It makes the acid problem inside the cells even more severe. And that's the central paradox we really have to wrap our heads around.
Okay, let's break down the chemistry here, but don't worry, we'll keep it simple. Out in the bloodstream, bicarb does its job. It buffers acid, it creates carbonic acid, and then that splits into water and carbon dioxide. But here's the kicker. That CO2 is like a tiny little traitor. It zips right across the cell membrane way faster than bicarb ever could. So it floods the inside of the cell and creates more acid right where it matters most. So you see, you've just made the acidosis worse at the cellular level.
Okay, so if chasing that bicarb number is a trap, what's the real breaking point? What's the actual danger signal we should be glued to?
Right. This is the most important question. We have to shift our entire focus away from that misleading bicarb level and lock onto the one metric that tells us when the body's systems are truly, fundamentally starting to fail.
And here it is. This is your number 7.10. Don't think of it as just a lab value. You need to think of this as a physiologic breaking point. Because below this pH, the actual machinery of the human body just starts to break down. A pH below 7.10 is the cliff's edge. Seriously, your heart muscle weakens and can't contract as well. The risk of deadly arrhythmias just skyrockets. Your blood vessels dilate, your blood pressure tanks, and guess what? The pressors you're using to prop it up, they stop working as well. Everything starts to fall apart, and the risk of cardiac arrest goes way, way up. So, the takeaway here is beautifully simple. Stop chasing the bicarb number. It's a distraction. Instead, focus on the patient's pH and their overall clinical stability. If their pH is above that critical 7.10 threshold and they're stable, you have time. You have time to treat the underlying cause. Okay, so how do we put this into practice at the bedside? Let's build a simple, reliable framework you can use every single time. This is your 3-point safety check for every patient with metabolic acidosis. First things first, check point 1. Look at the arterial pH. Is it below our cliff edge of 710? If the answer is no, you can almost always hold off on the bicarb and pour all your energy into fixing the root problem. Second, and this is huge, look at your patient. Are they unstable because of the acidosis? Is their blood pressure dropping off? Are they needing more and more pressors just to stay afloat? If the pH is, say, 7.15, but that patient is circling the drain, that's a huge sign you might need to intervene. We always treat the patient, not just the number. And third, checkpoint 3, how's the body's own defense system failed? The lungs are our #1 defense against metabolic acidosis, but they can get tired. They can't keep running that marathon forever. And when you see that respiratory compensation start to fail, that's a major, major red flag. So what does failing actually mean here? Well, we can predict what a patient's CO2 level should be when their lungs are working overtime to compensate. If their actual CO2 is higher than what we predict, it means their lungs just can't keep up anymore. They're getting tired out, and they are losing the battle. This is a critical danger sign. Now, there is one major exception we have to talk about: the intubated patient. They can't compensate on their own. They are completely at the mercy of the ventilator settings we give them. And if those settings aren't enough to blow off CO2, it's going to accumulate and drive that paradoxical intracellular acidosis we talked about. So for this specific group, you have to consider giving bicarbonate earlier.
Okay, let's put it all together. Let's crystallize all this information into one gold standard rule that you can take with you and use every single day in your practice. So let's summarize the whole thing. The trigger to give bicarb is not a specific bicarb number. It's one of three critical events. Either the pH drops below 7.1, or the lungs are failing to compensate, or the patient is becoming hemodynamically unstable because of the acidosis. One of those three. This is called a CCRN gold pearl for a reason. It's one of the most clinically relevant, testable concepts you need to know. Burn this sentence into your brain. This is your algorithm. If any one of those three conditions is met, it's time to give bicarbonate, while you are aggressively, and I mean aggressively, treating the cause.
So there you have it. You've got the tools now. You understand the danger, you know the true breaking point, and you have the 3-point safety check. The next time you see that crazy low bicarb and you feel that temptation to just give a dose, you'll know exactly what to look for instead. So the question is, what's the first thing you're going to check?